Hello, everyone. Welcome to the Alberta Transplant Institute seminar series. We want to just start out by welcoming all of you and acknowledging that the seminar series is supported by Paladin, who are great supporters of the work of the Alberta Transplant Institute. So I'm very happy to welcome you today. Our speaker today is Dr. Denis Djogovic. He's a clinical professor in the Department of Critical Care Medicine at the University of Alberta. He's medical director of the E.G. King Critical Care Unit and Neurosciences ICU, and specifically in the field of donation. He is also the medical director of the HOPE program, which is the Human Organ Procurement and Exchange program. He's got many clinical and research interests in emergency medicine, in trauma care, and clinical practice guideline development. Importantly for our program today, Denis is the co-lead for the SEND program, Specialists in End of Care and Neuroprognostication and Donation, which was launched by the government of Alberta in just this past summer, so just a few months ago. And the SEND program supports a network of specialists in end-of-life care and donation that is active throughout Alberta. And we're very excited about this step forward, and we're going to hear all about the SEND program today from Denis. So I will, Denis, turn it over to you. Welcome.
Thank you very much, Lori, and thank you to the Alberta Transplant Institute for asking me to join your lecture series. You guys are doing a fantastic job of broaching a whole distribution of topics and lectures from donation to transplant and research to clinical. So it's exciting to be a part of. I think I'm always learning. And so first and foremost, welcome. We'll take a quick session to go into a program that is just starting. So really there won't be much in the way of results or output. Really, it is the introduction of a very exciting initiative in Alberta. The Specialist in End-of-Life Neuroprognostication and Donation Physician Program. And really it's more than just the physicians. It is far more than just the physicians, actually, which will make this program so valuable. Before I start out, I'd like to provide many thanks to Carrie Holliday, who's our SEND project manager, and Dr. Andreas Kramer, who is my character foil for Alberta South. A lot of work has been put into this grant proposal, and then the grant, and now the production of this. And there's many more names that should be included here with regards to assistance in getting this going. But I think before we start out to talk about the SEND program, really we need to take this back to the clinical world and asking the questions of why are we doing this and what's the point. So I'm going to present a case. The details are not specific details to this case. However, they are unfortunately familiar enough that they've, over the past number of years, that the details are related and similar and unfortunately seem to recur. But let's take a quick walk through a case. So this is a case of a male in his 30s. He was at a house gathering and he is witnessed by his companions to inject what they think is fentanyl. There's a loss of consciousness. There is no Narcan kit on scene. And minutes later, the companion recognizes that he's not breathing. They start bystander CPR. They initiate EMS, and emergency medical services arrives and find this young male with no pulse. Resuscitation is underway, and after about 18 minutes of resuscitation, there is a return of spontaneous circulation. This young man is transferred to the nearest hospital and makes his way from the emergency department to the intensive care unit, where he has a Glasgow coma scale of 5 on 15. So again, all of us on this call are a 15 on 15, and a 3 on 15 is as low as you go with regards to measurements. So 5 is indicative or suggestive of severe neurologic deterioration. The patient is treated with 24 hours of targeted temperature management in the hopes that this may decrease the amount of neurologic sequelae down the road. Unfortunately, it's found that he has frequent seizures and myoclonus, which are suggestive of poor outcome at this early point in time. Without being a neuroradiologist, I can walk you through this image of a CAT scan of the head, but for a young male, this is not a very good CAT scan. There are very little in the way of what we look for cerebral sulci and sort of the wrinkles at the end of the brain. there's a loss of gray-white differentiation, and there's an overall suggestion that there is diffuse swelling and damage to this sensitive brain. At 3 days after the event, the assessment of this patient shows that there is spontaneous breathing. There's no pupillary reflex, no purposeful movement. Purposeful being that if you were to pinch an ear, would the patient be able to lift their hand up and push you away? There is felt to be slight extensor posturing. A family conference is held and a diagnosis of hypoxic ischemic encephalopathy is provided. And what that means is that the brain cells have suffered an event without oxygen and therefore have deteriorated and suffered an injury. The prognosis at this point in time is a near zero chance of a meaningful recovery. This is not a prognosis of survival. This is a prognosis of what are the chances of this young man leaving hospital, being in a non-hospitalized state without 24-hour care. The medical team has gathered and recommends a withdrawal of life supportive therapy at this point in time. And the family, appropriately enough, feels that they need time to consider this sort of diagnosis. They come back at day 5. The family is gathered and they agree that, knowing their family member, our patient, the withdrawal of life supportive therapies would be in keeping with what the individual would want if they were able to be part of this conversation. And then they ask, he made bad choices for his life, but he always wanted to help others. Is there anything good that can come of this? And this is where we start. If we go back to 2006, it doesn't seem like a long time ago, but it actually is. That's a good 15 years. The discussions of donation after cardiocirculatory death in Canada had begun. Actually, the discussion started before that with a large Canadian forum. Our own Jim Fitzjanis was part of this discussion in 2006. National donation leaders like Sam Shemy were part of this work. John Doster, you may recognize that name from the John Doster Health Ethics Center here at the University of Alberta. So a very broad group of clinicians, ethicists, and other individuals as well to look into a different way of donation, separate from the traditional neurologic declaration of death where a patient is declared to be brain dead and donation happens after that potential. This is a situation where a severe neurologic injury occurs that has an individual that will not show signs of neurologic recovery, and a family and medical team decide that a withdrawal of life supportive therapies is indicated and desired, and a plan to proceed to donation after the patient passes away. We'll go into some of the details here in a bit, but really this work back in 2005, 2006 established the medical, ethical, and legal framework for the practice of donation after cardiocirculatory death in Canada. When did this all begin here in Canada? A young lady, Sarah Beth Therian in Ottawa, had suffered a sudden catastrophic event, which led her to be severely neurologically impaired, but not brain dead. The family and the medical team had decided that yes, withdrawal of life supportive therapies was what Sarah would want. Interestingly enough, this is a situation where Sarah and her family had recent discussions before the event that Sarah indeed wanted to be an organ donor under any circumstance. And the family had heard about donation after cardiac death and was aware that discussions were underway to try and make this happen. It wasn't ready at this point in time at, I believe it was at Ottawa Hospital. So the policy wasn't prepared and the hospital wasn't ready to proceed, but the family insisted. They said, this is what Sarah would want, and we need to make this happen. And they did. And Sarah became the first modern day donation after cardiocirculatory death in Canada. We say modern day DCD because when donation first started, actually DCD was the process. This was before medical legal definitions of brain death had been created. So when donation first started, it was as a form of DCD. Once the neurologic declaration of death had been defined, we moved away from DCD because it was that much more controlled to have an NDD type of situation. But this is the history in Canada for modern day donation after cardiocirculatory death. The principles, and I'll provide the ones from the Edmonton zone, really are based on those 2006 national recommendations for respect for life and dignity of all individuals, optimal end-of-life care that respects the holistic well-being of the dying patient, respect for patient autonomy, support for the grieving family and loved ones, and most importantly, public trust in avoidance and management of actual and perceived conflicts of interest. What this means at the bedside is that the decision to donate must be separate from the decision to withdraw life supportive therapies. And it should not be a parallel process. It should be a sequential one where first the team and the family decide that a withdrawal of life supportive therapies is in fact what the patient would want. And once that is decided, then the movement towards deciding and discussing organ donation would occur, and trying not to have a situation where we mix or overlap or have one based on the other. When we look at deceased donors in Canada, including all types of donation, we can see that there has been a slow incremental rise over the years of sort of the 2006 to 2016. These slides are from Canadian Blood Services, so thank you very much to CBS for their ongoing support of all these issues. But really what we're seeing is the changes in donation are based on the when we look at these green bars, there's two colors to the green. There's the light and the dark, and the light greens are the neurologic declaration of death organ donations, which for the most part go up and down a little bit, but have not skyrocketed in numbers. The real change over the past decade and a half has been in that dark green, which is the donation after cardiac death. And you can see those numbers are going up and providing us with an increased availability for organ donation, which is so important from the transplantation side of things. CBS has also looked into what are the factors that contribute to higher donation rates. How do we make more successful organ donation programs? And there's a number of things on the list, but three of them that pop out as what is felt to be very strong are the presence of donation physicians, mandatory referral of potential donors, and the implementation of DCD. So where are we in Alberta, or where have we been? DCD was implemented in the Edmonton zone for Northern Alberta in 2010. The Southern zone in Calgary continued and supported and came into procedure with this in about 2016, and maybe off by a year or so. The donation physicians have been there, but we'll go over some of the details for that. Mandatory referral of potential donors is an ongoing discussion point. Alberta does not have mandatory referral. Alberta has mandatory consideration of potential donation. And what that means is a situation that is still a little difficult to wrap your head around, but essentially it means that the physician and medical team have to consider donation. I'm not sure how you have mandatory consideration. There's things that we all consider on a daily basis, but doesn't mean that it was effectively considered, doesn't mean that it was considered in a realistic sense. These are the situations we get left with that are still a little bit cloudy. I put the summary slide from CBS to show all the issues that they were pointing out in their presentation. But when we go to that middle spot of saying in Canada, the deceased donation rates are the highest in 4 jurisdictions, British Columbia, Ontario, Quebec, and Nova Scotia, you'll notice that Alberta is not in the top 4 provinces of Canada. From a transplantation side, we are certainly amongst the top. We have world leading centers here at the University of Alberta with regards to transplantation in liver and multivisceral transplant and in thoracic organs as well. But we're not even in the top 4 within our own country for donation. And certainly that is a point that we have to address very seriously. Work before 2015, leading into a 2015 publication of Deceased Organ Donation Hospital-Based Review. This was completed by Drs. Kramer, Katsigiannis, and many, many members of HOPE in Southern Alberta organ and tissue donation programs, looked at an audit of donation potential and efficiencies, essentially looking, where do patients die? Where are the patients that could have organ donation potential? Are we missing them? Are we addressing all of them? And what's the most challenging thing about this large undertaking was that the information did not really become available for publication until 2018. And when we look at any kind of feedback from our input, if it's a quality assurance type of process, information that comes in real time or close to real time can make a difference. When information is coming back years later, it's really hard to make those changes to what happens on the ground because you're looking so far in the past How do you influence what happens in the present day and continue that process into the future? In 2011, there was a call to action from Canadian Blood Services for donation physicians saying that donation physicians should be available in all hospitals that provide donation care. They should provide leadership in creating a professional organized culture of donation. And I want us to keep in mind that organized culture of donation phrase, because it's going to come up later. With regards to identification, referral, and consent, and approach and utilization, the whole hope of this process is the downstream process of increasing organ transplantation. But really, we have to start out with assessing and recognizing organ donation potential. Looking at donation physicians per million people of population across the country, I think this bar graph from 2018 sort of puts it into play. You can see that there's heavy investment in a handful of provinces, and there are some provinces that were suffering quite a bit. And Alberta, again, as one of the leaders, not just in the country, but the world with regards to organ transplantation, you can see how far back we lag with regards to investment in donation physicians. This map of the country from 2018 puts it into better perspective. You'll see Alberta with 2 yellow stars, and those 2 physicians are Dr. Kramer farther south and myself right in the middle there. But if you look at the other provinces, Quebec, British Columbia having about 12 donation physicians across their province, Ontario with very heavy investment with about 60 or 70. And certainly Alberta does lag behind in that. Does that mean that our outcomes are different? Hard to extrapolate that, but certainly the suggestion is there that we are lagging behind in the support from those donation professionals. Which takes us to the SEND proposals. So there have been discussions going on for years with regards to increasing support for donation physicians. And over the past few years, between HOPE and Southern Alberta Organ Donation Tissue Programs, we've made quite a bit of a push with the government to see if they would support what we were phrasing as a specialist in end-of-life care, neuroprognostication, and donation. So not just oriented to donation, but really towards improving and increasing the satisfaction of end-of-life care and assistance for those processes. There were ongoing discussions between ourselves and government and various levels and supporters, and we were pleasantly surprised in about December 2020 that Alberta Health and the government of Alberta did want to support this and gave us the funding to run a 3-year grant to try and improve those situations, so not just from physicians, but also from real-time data acquisition, feedback, outreach, and hopefully changing things into the future. We started the program in May. Clinical services began in sort of a overlapped June, July perspective. The biggest struggle with the SEND program, and I'm sure it's reflected so many of the programs out there, has really been recovery from COVID wave 3 and then the reinitiation of COVID wave 4. To give everyone a little bit of reflection of how that has influenced a place like the SEND program and donation across Alberta. Our SEND physicians are all intensivists, and all the intensivists are probably working 1.5 to twice as much as they normally do to deal with the COVID wave. Even from the HOPE program here in based in Edmonton, 1/3 of our HOPE coordinators have been redeployed to the bedside. So starting up a brand new program that hopefully would be very very robust and very thorough has certainly been stalled because of our recent struggles. But the hope is that we can get back and moving very soon. From a physician standpoint, what the SEND program has allowed us to do is increase the number of donation professionals across the province. These are not each being singular full-time physicians. These are all physicians that have intensive care practices, but have obtained some funding and support to add donation professionals under the list of things that they already do. And the way we've split it up is we've added 6 SEND physicians in Edmonton and 6 in Calgary. But we've gone beyond there. We've also added representatives from Alberta Children's Hospital and representatives from the Stollery Children's Hospital. And we've also managed to include larger centers that have ICUs in Grand Prairie, Red Deer, and down in Lethbridge as well. The hope is that we can continue to push this through and include other sites like Medicine Hat and Fort McMurray when appropriate. In addition to this, we have a program manager, a project manager, Carrie Holiday, who's done some fantastic work so far and has quite a bit of experience in the world of donation and audit, and our administrative assistants to help each of the major sites. So a big team has come forward and they're all ready to go and have started their work. And we're really excited to see how this distribution of professional support can change the culture of donation in Alberta. The physicians have clinical responsibilities, and there's a list of them here, but really it is to do all sorts of stuff to help and support donation at the appropriate center. So being a second physician for neurologic declaration of death assessments, being a second physician for opinion or consults for possible DCD cases, acting as the second physician for donation after cardiac death determination. In the DCD process, we always need 2 physicians to be there and present at the time, and the SEND physician allows much easier arrangement of having those people ready. Traditional DCD practice usually entails that the most responsible physician acts as physician 1, and then frankly we have to scramble to find physician 2 that doesn't get pulled away at an inappropriate time. When needed to help with conversations with families, consultations in identification and management for organ donors, or procedures that would support donation assessment and management, the SEND physicians are available for that as well. Collaboration is an important one. We recognize that any place within the medical system that has a ventilator will have patients that could be considered for organ donation. That includes emergency departments, it includes coronary care units, and includes our traditional ICUs that we always look at. But we want to find a way to distribute our SEND physicians so that they can collaborate with each of these departments. Certainly for Edmonton, the way we've laid it out with our 6 physicians is that we've linked them with local hospital sites. So, we would have physician X being the linkage with the Grey Nuns Hospital, and not only could they provide the outreach and the feedback to the processes happening at the Grey Nuns Hospital, but they can also help them work through the challenges that they have on the ground. I think if you go back to that earlier map of the country, there's the 2 physicians for Alberta. Andreas and I are pretty effective, but it's hard for me to dictate change on the ground at a hospital that I don't work in. And it's much easier to have a linkage with a physician that works there, that can be present there, that can have that input and really learn about the culture that's existing at that hospital to see what can we do to improve the situation or help move it forward. The regular data will be an important one. We'll kind of bring that up with our outreach process. But the education part is going to be very important, certainly supporting all of the medical professionals with regards to knowledge about organ donation and where to get the best information, how to provide that information. Quality improvement will be an important one as well. Can we see that processes are being performed optimally? Do there have to be changes that we make? Can we recognize these sooner rather than later? And having regular analysis of organ donation metrics would be extremely important, not just in providing, gathering the information, but also providing it back to those sites that are contributing to organ donation. So again, how can a certain hospital that is not a regular DCD site learn about their outcomes if they don't get the information with regards to it? So having our SEND physicians and linked HOPE coordinators and SAODP coordinators as well, link with those hospitals to be that recognized face for how are we doing? What are the numbers showing? Are there cases that we're overlooking? Are there challenges that we have locally that are not there in other hospital sites that we need to address to improve organ donation? The medical record review will be an ongoing process. And, when we look back at the chart audit of 2015 that took a handful of years to move forward and get published, the hope is that we can do a situation where we gather the information regularly. And Carrie has been working on gathering and creating a very robust system to gather that information in fairly real time, so in under about a month or 2 from the event itself, so that we can redistribute that information back to those sites to let them know how they're doing. And finding those quality gaps is going to be the important thing. I think there's going to be a focus, and there's always a natural focus to see, well, what does it mean from outcome being organ transplants. But really the focus has to be much earlier. It has to be at quality gaps. It has to be, are we doing the right thing all the time? The transplantation numbers will come later, but we have to work on that early quality portion. When we look at units in scope for medical record reviews, there are a surprising number of places within Alberta that we have to address. There are 16 emergency departments that have ventilators. There are 20 intensive care units. There are 14 neonatal intensive care units and 3 pediatric ICUs. So when you look at that distribution across the province, we have to make sure that not a single one of those departments is overlooked, because each one of them can have an influence on organ donation and on the culture that we're trying to create. The metrics are going to be the numbers and the outcomes that are sort of the easy ones to report. Organs transplanted being converted to lives saved, organs transplanted per donor, actual donors, consent rates, approach rates, referral rates. Missed eligible patients are going to be an important one. So these would be patients that when we look back at, we say, this individual that passed away had all the indications and all the parameters that would have included them in organ donation. What were the reasons that they were not referred? Was it oversight? Was it local culture? What were the indications for it, and what can we do to work with that? But at the end of the day, we have to take away the numbers, and we have to push away the metrics, and we have to focus on the utilization of a program like this to help develop and broaden out the culture of donation. Because at the end of the day, organ donation is a very unique program. If you want to create a trauma program, you hire your trauma professionals, you obtain your trauma procedure interventions, and you get ORs ready, and then you open the doors and you wait, and the traumas will come to you. Organ donation is very different. Organ donation only happens through the trust and the inherent goodwill of the people of our province. That is how donation happens. And we need to make sure that our culture of donation is ready for those offers, is ready for those gifts. And that is, I think, the true goal for anything with regards to donation. And certainly a program like this will be supported in creation of a larger, more robust culture of organ donation. I'd like to provide many thanks for this first at Alberta Transplant Institute. The more we, if you're going to create a culture of donation, you need friends and you need collaboration, and having ATI be part of that is very valuable. From a Northern Alberta person, having the collaboration and community to link with Southern Alberta Organ and Tissue Donation Program is extremely important. The professionals in the HOPE program for their unwavering dedication to donation. And, I didn't put on the slide because I don't think I have a slide that is robust enough or important enough to provide thanks to Alberta, to the people of our province, of our country, that undergo these life-changing circumstances in their family and somehow find it in their hearts and in their family support to provide organ donation as an effort to prolong the legacy of their loved ones and to truly change the lives of strangers, of people within their communities that they've probably never met. So I don't think I can make the slide that's appropriate enough to provide that kind of thanks, but I have to include that for sure. Laurie, that's all I have for this presentation. The hope is that in a year, in 2 years, we'll be able to sit down and regroup and redo this presentation and show you some numbers and show you what sort of differences we've made from that culture, also from the metrics that we're looking at. But I'm very pleased to be able to present the early workings for what I hope is a very powerful program.
Great. Thank you very much, Dennis. That's so helpful to get an overview of it. I know we've got about 80 people in the audience who've been keen to hear about it. And I know we'll have questions, and we already have some that I'd like to just ask you. One question just coming from me, so Ontario instituted their program about, I don't know, I guess about a decade ago. In the development of the SEND program with specifics for Alberta, were lessons taken to how to best institute such a program? It may be different, but there may be similarities too. How much did you learn from not only Ontario, for example, but the other provinces and even international jurisdictions on how to structure such a program?
I'll start out with saying that that was sort of before my time came around with involvement in donation. But, I think the principles and parameters of that early work in 2005, I think laid the basis for DCD across the entire country. Although there are going to be regional differences in what type of hospital DCD is provided in, how the approaches are done. Overall, the process of DCD is fairly similar across the country. And the work of Trillium and other sites across the country are fairly similar in what we have for DCD.
No, I mean for the donation physician component.
Oh, okay. Yeah, and that one's a different one. I mean, we certainly came at it from a different perspective, where we had more of a regionalized physician base with heavy coordinator involvement. To bring up the ideas of having more donation physicians. Really, we had to look at our own distribution. I think Alberta is unique, along with a handful of other provinces, where we are very centric in two areas, but somehow we have to pull in all those other sites. And so I think the plan wasn't necessarily based on any one provincial approach, but probably took into play a lot of the variables that they were challenged with as well.
Terrific. Let me just come to some of the, thank you. Let me come to some of the questions. We have from Dave Hartel, we have a link to the data on DCD across Canada. That's from CBS. That's very helpful. We've had a question from Robert on, would I, as a long-term hemodialysis patient and failed kidney transplant, be eligible to be a donor? And I sort of took a stab at that and advised that eligibility for organ and tissue donation is based on many individual elements and considered on a case-by-case basis. Would you like to add anything to my response to that?
Robert, wonderful question. I think that is the big appropriate one. There's so many parts to donations. I guess the bigger question is, can a previous transplant patient be a donor down the road? And I think one question that would come to my mind is, donation incorporates so much more than just a certain organ, like the transplanted one, but the other tissues and organs as well. I think we do focus on organ donation, but tissue donation is just as life-changing for so many others. So I would say that certainly you can be a donor. The biggest question would be what potentials for organ and tissue could be from that individual. So thank you, Robert, for a very important question.
Okay, thank you. We've got some more from Murray Wilson. Is the question, is the quote unquote sequential decision-making, number one, withdrawal of life support, number two, discussion regarding organ donation, is this a question of law or a question of clinical practice, or both?
Really, it comes down to clinical practice and clinical ethics. I don't think there's anything with regards to the law that would prevent that. And, when I say sequential, it's not a situation where, if someone was neurologically injured and, discussions hadn't been with regards to organ donation, and a family brought up, can we talk about organ donation? Really what would happen then is that we can say that certainly there are things we can discuss and we can give you the ground level view, but we can't go into specifics about your loved one until an appropriate time. And really what we don't want to happen with DCD is that motivations for withdrawal of life supportive therapies are based on the process of organ donation. We don't want the one to influence the other. The hope is that the decision to withdraw life supportive therapies is because it's the appropriate thing to do for the individual and for that family. And then when that decision is made and solidified, then further discussions can happen about, is there potential for organ donation? So, we wouldn't want to run away from the question. The hope is that we would redistribute the timing of the details of that question, just so that we don't have that situation where there seems to be an influence on decision making based on something that might happen down the road.
Okay, thank you. Oh, and by the way, people can also raise their hands. I'm just going to go through what's in the chat box at the moment. From Ann Halpin, is there a plan to coordinate with MAID programs and clinicians when a MAID candidate expresses an interest in donation? And just to decipher that acronym for anyone who's not familiar, that's medical assistance in dying.
And great question. So medical assistance in dying, once it had come into play with national jurisdiction and legal approach to be legal within the country, there was a natural discussion after that with regards to, well, what if that could be performed at or at the concurrent time of donation after cardiac death? And in fact, that is occurring. Other provinces have pursued it for a while. We have been in Alberta supporting that since about 2018. They are not common cases, but it has to be included when you think about what are the goals of medical assistance in dying. And I think it is really patient and individual specific. It is person specific to what their wishes are for their body and for their life. And if organ donation is an important thing to them, it is very possible and can be done that MAID linkage can occur and lead to donation after cardiac death. It does follow the same sort of principles that we just discussed with regards to sort of that sequential assessment. We wouldn't want the MAID decision-making process to be based on a desire to be an organ donor. And the MAID program does a very thorough job of the assessments for the individuals who come forward to them to see if they can qualify for MAID. So those questions are usually held until after the MAID process has been approved for that individual. Then donation questions can occur.
So they are linked then in terms of having a mechanism for the introduction of the concept somewhere in the process of after the MAID discussion.
Right.
I've gathered that I've seen some case reports of that where the coordination then gets really complicated, and that's but it's quite encouraging that if there's a patient seeking to be a MAID candidate, that there is an ability to allow their wishes to participate in a donation opportunity to also be considered. We've got a hand up, David Hartel, who's known to many of us for his work with the CDTRP and with Canadian Blood Services. David's in Ottawa today. Hello.
Hi, Laurie, and hi, Dennis, and everybody. Thanks for the presentation. Fantastic work being done, and I'm really excited to see this moving forward. So I have I had two questions for you. So one is, I find that the concept of this, first of all, it's called donation physicians everywhere else across the country, but Alberta, likes to be different and unique. And so I love this concept of a send physician, but I'm wondering if you could sort of speak to this concept of, why didn't you just go with the term donation physicians, and what does adding the terms end of life care and neuroprognostication to the title, like what does that change about the role or the philosophy coming into it? And also, how does that change the way you evaluate the impact? Because what you were talking about was really donation focused. And maybe I'm, preempting your answer to the question, but if you're also focusing on end of life care and neuroprognostication, how does that change what it is you're measuring? Because I'm assuming then it doesn't only mean about the number of organ donors that come out of this. So that's my first question. And then my second, I guess, related question is about some of the metrics that you were proposing, which are really about like counting, seeing an increase in the number of donors, which we all want to see. But I'm wondering if an intermediate step between now and then is really trying to measure changes in the culture of donation. So how do you actually go about measuring that beyond the donation physicians or the send physicians who have already bought into donation, but the rest of the ICU and emergency community? How do you measure a change in the culture of donation for that community.
David, always excited for the challenge of your questions from someone who knows more about this stuff than I do, for sure. You know, I think when I look at organ donation, you know, as a clinician, what we're trying to do, and I think at the end of the day, is make sure that we have no missed potential opportunities. One question that comes to mind for myself as a clinician is, what about other physicians? Do they support organ donation? Is that something on the forefront of their mind? And when we look at the SEND program, really the focus needs to be on, can we provide the best end of life care for our patients? And if I were to, and again, this is more personal, but if I were to ask other physicians and say, what do you think constitutes excellent end of life care? I think there are going to be the automatic responses of, well, you know, if the family has special religious or cultural observances they want, we would support that. Of course, we would for end of life care. We should make sure that palliation of symptoms, whether pain, discomfort, or agitation, has to be there for end of life care, for sure. You know, if there was a time of day or another timing perspective or something that's special to that patient, we would go out of our way for best end of life care. And I would have to say that end of life care has to include the offer for organ donation. You know, when we look at organ registries, and you know, whether they're online or driver's license related, these are patients who are individuals who've had the chance to think about organ donation. So, but does that mean that someone who's never thought about it wouldn't want to have that as part of their end of life care? And I want to make sure, and again, this is more of a personal thing, but how do we make sure that we don't forget to offer that to other people? We would never institute end of life care and not offer to a family, say, you know, we can palliate symptoms, not for hastening death, but for palliation of symptoms so they can be discomfort free. We would always offer that, even if they didn't ask. We would always ask and say, is there anything that your family or your, you know, cultural or religious observances would be of interest at this point in time? We'd offer that even if it wasn't questioned. And I think organ donation needs to be part of that. So at the end of the day, you know, I do agree that the real focus is donation, but we have to link it with end of life care. I think that's where that culture change comes from. For, you know, maybe I have clinicians and colleagues that don't normally support organ donation, but of course they support end of life care. But organ donation offering and you know, existence has to be there as part of end of life care. From your second question with regards to what are the things we're going to look for downstream, as with regards to are we successful, when it comes to metrics, the one that comes to my mind as being the most, probably the first thing that we would see is, can we increase donation approach rates, right? So maybe it takes a number of years to show the changes in organ transplantation, but if we see that there's, you know, 25% of patients are offered organ donation, and 3 years later we say 75% of patients are offered organ donation, that's, I think, the start. That's where the culture starts to turn around from and change.
Thanks for that question, David. Does that get at what you were looking for? Are there other elements?
Yeah.
Sorry, go ahead.
No, absolutely. I think that's great, Dennis. And I really do think, you know, this approach in Alberta, I think, makes a lot of sense for where Alberta, like sort of Alberta's approach to donation and transplant. So I think it's a fantastic approach. You know, I would suggest in some of the metrics, some of the things, you know, even beyond approach rate, some of the things even before that you can start looking at is around education and awareness. So if we start looking over time, over the next couple of years, and say, okay, well, even if we were just to start measuring now, what are attitudes, general, even in your target physician and coordinator and nurses population, what are people's attitudes and awareness and understanding of organ donation processes? How does that change over time over the next 3 years? Because that's presumably your first line of, you know, we just have to educate people to make sure they understand when to refer, how to refer, what type of patients, like even if you can start measuring those things and showing that, because of the work you've done, like people's general understanding and general attitudes towards donation and transplantation improves over time. Like that's even a first step before looking at some of the, or in conjunction to looking at some of the numbers.
You know, and David, I think one of the, I guess not a fear, but one of the things we'd have to think about is if we find patients that did not have the offer of organ donation and we go back to that medical team, and if we were to ask them why not, because they seem to fit, I think it would be, what we don't want to hear is, well, I didn't think they'd want to donate, or we didn't think they would be a good candidate. What we'd like to do is create a culture where we, you know, the medical team, we don't place our values or our interpretations of what the family would think, right? Or I'm uncomfortable discussing it, or, you know, you don't have to discuss. All you have to do is bring it up and we can get those discussions going. So I think those are going to be very important from that culture perspective.
Yeah, I think those are really, really getting at the more nuanced elements of beyond the numbers and what's the impact of this, and how can you assess it? How can you evaluate it really broadly amongst the various communities, including the citizens of Alberta, you know, who are impacted by this on a kind of public level. We have, let me just go to another question here. Murray contributes, again, Murray Wilson just contributes a comment. This is a very impactful presentation, Dennis. Thanks so much. And then we have, oops, sorry, I lost my questions here. 1 second. Yeah, a question received by email. Do you speak with families about the option of tissue donation as part of this program? So tissue included in the donation process, not just organs. Great
question. It should be. It should be part of that. The tissue donation process, because it's not as time sensitive, often happens after the fact, but the donation question has to include all of those factors. And, you know, again, there's a push from organ, not a push, but I think there's that inherent feeling of, you know, solid organ transplantation is that the main goal, but then we recognize how important tissues are, you know, heart valves and skin and so many other things that can truly change lives. We can't afford to miss out on those.
So that is included in the general discussion. From Donna Velhon, is there a data feed from registry question, i.e. choice on license, to the medical records? Can there be to trigger calling the SEND program?
So when the organ donation organizations are involved, they will do registry checks to see if, whether online or through the driver's license programs, if consent has been stated before. You know, one of the challenges is that although there is consent with regards to online registry, really it's more of an intent. The consent really does involve those bigger questions and the more detailed questions that the family brings in, but that indication of intent and support is so important. And we will always look into those charts, but truly from the bedside, it's tough to do. And I'd say that most clinicians and most treating teams aren't doing that.
And so will that be, what you just said then, in the wider evaluation of the impact of the SEND program, will that be able to be assessed and measured?
It certainly could. I think that the issue is the access to the registries, and not everyone can get access to the registries. So certainly our organization coordinators can and do, but from a bedside physician to be able to access that is actually very difficult to do. But it should be part of the numbers that come up, especially because it would be a huge red flag if an individual that we reviewed after their death that was not put into the position of being possible for organ donation discussion was someone that had registered intent. That would be a huge discussion point to see why not. How did we miss this one?
Yeah, for sure it would. And the timing that could make that smoother and easier. A question from Kieran Halloran. Thanks for this, Dennis. Very exciting to try to get Alberta's donation rate up. I'm curious, once the data from the ICU is collected on their missed donation opportunities, how will that be fed back to them, and what actions will be taken from there?
Yeah, I agree. Kieran, the data is great, but we have to get it back to the people that can impact make the changes. And what we're planning to do, and that's where sort of our send physicians are linked with those hospitals. So if I were to use the example of, let's say, the Grey Nuns Hospital, and I have a send physician that's linked to that site, they're going to have that regular feedback and collaboration with those sites. And the hope is that every 3 to 6 months that they would meet with those programs and say, okay, so for the past 6 months, here's some information with regards to your organ donation rates. We found 5 charts where maybe there were situations that we can't quite figure out why donation wasn't brought up. Can we go over some of the details of these cases to see what we can do on the ground? So that kind of gives it a bit more of a localized influence, as opposed to saying, in Edmonton, here's the kind of cases we're missing. Whereas if we go to a certain hospital and say, here are the exact cases that we found that weren't brought up, not in a punitive way, not in a argumentative way, but in a collaborative way, to say, well, all we can say is it looked like these patients could have been included. They weren't. Maybe there were very legitimate reasons for this, but maybe we can talk about it. And in those smaller areas, we might make those cultural shifts to use the data to make changes into how behavior is on a day-to-day basis.
Does that answer your question, Kieran? Did you have any follow-up questions?
No, yeah, that's great. Thanks a lot, Dennis.
Just along the lines of your concluding point on that, Dennis, there's a question from Caitlin Mills. Will you be including any qualitative measures as part of your evaluation of the SEND program? Physician experience as members of this network may provide helpful insight into your goal of building a culture of donation.
I think a program like organ donation has to be heavy on qualitative data, because it's more than just the numbers. It's really about how we make changes in attitudes and changes in approach rates. So the measures that we have, there's, I'm sure Carrie could bring out a list of all the measures that would probably, lose most of us along the way, but we're going to make sure that we don't lose any data points along the way, that we can, will all of them have an impact on down the road changes? It's hard to say, but we have to start out with gathering everything that we can. So hopefully we're not going to miss anything. And we've been in discussion with CBS and some of the other donation audits that are going on across the country to make sure that at least if we're collecting data, it's relevant and linked to data that other organizations within the country would want as well. So we don't have to sort of go back and recreate things for things that we've overlooked or felt were more important than others.
Well, that's very timely to the next question, which kind of addresses exactly that. How do the metrics that SEND is using align with those proposed in the ongoing CIHI project on a pan-Canadian ODT data and performance reporting system? So that's, for people who don't know, that's a national ongoing Health Canada initiative that many of us are partnering on. Is the Alberta component here specifically partnering with CIHI on that?
I wouldn't say it's a specific partnering, but it was very timely in that the creation of our data outcomes that we're looking for were created at the same time as we were trying to address the national ones as well. So for the most part, we should be addressing the majority of them. I can't say that 100% are being addressed, but I would say that the large majority of indicators on the CIHI side are going to be addressed from our reviews as well.
Great. I think that's timely for sure. From Linda Powell again, is the grant funding for a determined period of time? Hopefully will be continued.
Yeah, the grant funding is currently it's a 3-year grant, and I guess that the question marks are at the end of that as to whether it continues or does it continue in a different form. And I think that's sort of our own struggle is we want to get up and get going fully for the most part, but donation has been truly affected. This past 18 months with COVID, the numbers are not what they normally are. Circumstances are very different as well. So will we see the changes that are going to show government that this is a worthwhile project to continue. I certainly hope so. But you know, at the end of grant mark, I don't know what will happen.
Yeah, well, it'd be helpful to have that continuously funded in a reasonable time frame, especially as you say, with the impact of COVID. Another question from Murray: should we have mandatory referral in Alberta?
Murray, fantastic question. I think, you know, it will be interesting to see what happens with some of the Nova Scotia data with regards to their mandatory referral. You know, they are truly leading the country with that initiative. Will it make changes? And certainly mandatory referral, it's still part of that. It's mandatory in the realm of it needs to be done, and we still need that as well, even in mandatory consideration. I think that our current process would like to make sure that everyone continues to think about it, that we don't lose out, but certainly mandatory referral would be a fascinating thing to introduce. And I just don't know what the outcomes are on mandatory referral and, you know, from a provincial perspective.
Murray, did you want to add to that?
Yeah, there's an interesting factoid that I don't have supporting data for, but you know, they announced their approach in Nova Scotia a year before they put the law into place, and over that year, the deceased donors per million number just skyrocketed. So I don't know if anybody else has any views on that.
Well, of course, that's not just mandatory referral, but that's I think you're referring, Murray, to the opt-out, to the opt-out legislation. Yeah,
exactly. But I mean, it caught everybody's attention before it became a law, is the point. And the whole system seemed to respond in a very positive way.
Dennis?
I think that we watch it with interest, and to see what, you know, our provincial bodies feel about supporting something like that, both from a societal and government perspective. You know, the other hope from the SEND program is that will it be a situation where clinicians are aware they're provided the feedback and the outcomes for what their patients are like, and maybe it'll make a difference when the next patient is brought to them that may be in a withdrawal of life supportive therapy position. Will it remind them to think about donation and to consider and hopefully not to miss out on any offered opportunities?
You know, this has been a terrific discussion, and it's nice to have the time. There's one last question from Linda. Why don't you go ahead and ask your question about the linkage with the coordinators and the SEND, Linda?
Thanks, Laurie. Just a brief comment too about the public education and awareness. Hopefully that can be eventually a component of the program, because public education is so important for the overall culture of donation. But certainly on a specific note, could you describe how the ODO coordinators work with the SEND physicians and what the process is there? Maybe it's a bit too much detail here, but that would be interesting to know how that works.
So our organ donor coordinators, whether in Alberta North or Alberta South, are, you know, the huge drivers of organ donation. They're the ones that make that first contact. They're the ones that do the first assessment and do the majority of the work with all organ donation in the province. You know, the SEND physicians are going to be linked, hopefully, with their coordinators. So, you know, again, from an Edmonton perspective, the hope is that, again, Hospital X will have a SEND physician that is known to be their linkage, and also one of the coordinators will also be the regular linkage as well. So they're sort of a tandem, or I guess a dyad you can look into to supporting these hospitals and their donation processes. We just need them to come back from all the ICU redeployment so that we can put them back to work with an organ donor.
Right. Yeah, absolutely. Thank you.
Well, I would just say there are, you know, we have a large number of patients and families in the audience today. There are lots of comments about congratulations on a start on this initiative, and supportive comments, Dennis and Carrie. I see Carrie Holiday there, your right hand, I guess. So I think this is really terrific, and we're looking forward with huge enthusiasm to getting past the pandemic limitations of what you've been able to carry out so far, and move forward. And you know, you have the the support of this whole community as well. David just adds, great initiative. Congratulations on launching the program. So everybody's excited to see it continue. Thank you very much, Dennis, for sharing this all with us.
No, thank you everyone for attending and for such valuable input.
Next week's speaker will carry on with our donation theme, and that will be Maxine Chartrand from the HOPE program, who will be kind of walking us through, why we do HOPE and how we do HOPE, a day in the life of a HOPE coordinator. So please register and join us next Wednesday. Thanks again, everyone.